طبعا بشكركم لحضوركم لاخر سيشن في المؤتمر، وانا عارف دايما ان النايت مير والريفراكتيف سيرجري بتبقى من السيشنز الجميله، يعني عشان البلاوي اللي بتتفرجوا عليها في حياتنا واللي بيحصل. طبعا لما الدكتور محمد حسني قال لي تشاركنا، بصراحه انا ما كنتش يعني عارف اتصرف ازاي او اعمل ايه. بشكر الدكتوره شيماء البسيوني طبعا لانها ساعدتني في البريباريشن اوف ذس برزنتيشن، وفكرتني بالحالات اللي احنا المفروض نحطها. فاحنا كلنا بنشتغل ليزك عادي جدا. جات لي ست عامله 48 year old lady that did LASIK since more than 10 years and came complaining of blurring of vision in her left eye, and her uncorrected visual acuity had been decreased to 0.05 in the left eye. And there was an epithelial downgrowth. طبعا the problem of epithelial downgrowth is still a big problem, that mostly when you remove the downgrowth from the stromal side and from the flap side, still the patient complains. All of us, when we see the epithelial downgrowth, we wait. If it affects the vision, yes, we interfere. But if it didn't affect the vision, we usually leave it to follow up. And this is the MS39 picture, or the anterior segment OCT picture of the epithelial downgrowth, showing how is this downgrowth extending to the center of the pupil. And the patient, of course, complained of decrease of vision. And as you see here, the flap is very regular, and this downgrowth should be removed. And the decision was taken after I heard a nice presentation from our junior staff, Dr. Mohammed Mansin, in one of our department meetings, that is removing the epithelial downgrowth and taking sutures of the graft, or suturing of the flap over it. So I decided to elevate the flap and scrap the stromal bed under the flap surface, putting the mitomycin C 0.02%, and sutures were taken. Let's see the video. And simply we mark before elevating the flap. Of course, in spite of 10 and 15 years, you can elevate the flap safely without being cut with a regular iris marker or iris retractor or chopper. And then this was under topical anesthesia, elevating the flap as usual, and taking it back. And you'll find the downgrowth is on the flap side, and also some of it on the stromal side. Careful removal of the whole stromal and the epithelial side, and after removal and ironing and removal of the whole cells from both sides, we put mitomycin C 0.02% for 1 minute. I left it for 1 minute. Of course, it's variable, different schools. Some keep it for 20 seconds, for 40 seconds. And the PRK, I'm leaving it sometimes up to 1.5 minutes with a very good scraping of the stromal side, and even removal of the epithelium from the edges and from the back. Everywhere I tried to remove the whole epithelium, and in spite of all these maneuvers, and then returning back the flap and taking 7 sutures like those of the keratoplasty, of course, partial thickness, as you're going to see now. Then we put the mitomycin C after cleaning of the flap side and the stromal side, and then turning back the graft, and after again removal of the whole epithelium from them, and even removal of the epithelium from over the flap side to prevent any migration of the epithelium from the flap or its bed, and then taking the sutures. Again, cleaning the flap, and then after turning the flap totally, taking 7 sutures. They're not so tight, not so loose, to prevent, aiming to prevent the migration of the epithelium again. There are several other ways, adding alcohol, putting the glue, and this was the picture after removal of the epithelial downgrowth. And first day post-operative, definitely there was a big difference between before and after. The media is clear, the patient is satisfied with improvement of the visual acuity. 2 weeks post-operatively, they're starting again of some epithelium that started to appear again under the flap, and the uncorrected visual acuity decreased to 0.4. 3 months post-operatively, there are more and more epithelial downgrowth again in spite of doing all these procedures. So definitely we are frustrated, and the patient is a little bit frustrated. I decided to wait. because the next step is to remove again the flap and to do glue for the edges with the sutures, and the glue is not available now. Astonishingly, after 6 months post-operatively, there is some more clearance of the flap with some improvement of the visual acuity that I cannot actually explain why the epithelial downgrowth started to decrease again. So I decided, let's leave this LASIK with the flaps and the complications, and let's go back to no more LASIK, go back to the PRK. PRK is safe, it is superficial, just removing the epithelium. The problem of healing, definitely most of the cases healed after even long time. Then I found a patient that came to me, 33-year-old male, that he did PRK since 3 months, complaining of blurring of vision in both eyes, with uncorrected visual acuity, counting fingers in the right eye and counting finger 1 meter in the left eye, with bilateral corneal infection and corneal melting. And this was the picture. One of the colleagues that did the case, and there was a delayed healing of the epithelium, and the patient reached this picture for the right and the left eye. I gave him, this is really nightmare, I gave him all the medical treatments after culture, sensitivity, it was fungal, and after the treatment by 1 week, I found there is more melting for the right eye, and the left eye is worsened, so I decided to do PAC cross-linking for him, as we heard from Rami in the previous section, and I advised him to do, after no improvement of the medical treatment by just 1 week, to do bilateral PAC cross-linking, and when he entered to the OR, or the outside office that we're doing the PAC cross-linking, because it's of course infection and we are afraid to admit the patient with the infection inside the OR. So one of his brother told me, what is this procedure? Is he going to see again after the surgery? I told him, now we are in a very big problem, and your brother is going to lose his eyes if you're not going to do this procedure. We have to just fix the cornea, and later on he will need definitely keratoplasty, and this is just to prevent the infection and to preserve the eyes. And I found that he's attacking me as if I did him the surgery, so I told him, okay, we are not going to do the surgery, as the expectations are not as you are predicting for this patient, and we can consult our dear colleagues in Cairo. I sent him to Dr. Mahmoud Ismail and Dr. Ashraf Hamaim, and the patient vanished. I don't know what happened for this patient. All of his concern was to go back to the original surgeon, to blame him or to deal with him in his aggressive way. But again, I said, no more PRKs, let's do another thing instead of doing this refractive surgery with these complications. So we are going to do the ICLs, be away from the cornea and go to the ICLs. I have my patient, he came to me, 36-year-old patient, seeking refractive surgery. Preoperatively, his uncorrected visual acuity in the right eye was 260, and he was corrected with -9 in the right eye, and he was suitable for doing smile surgery. And I did him smile for the right eye, but his left eye was -11, -3.5 astigmatism, and he was not suitable for doing smile surgery for full correction of the refractive error. So I decided to do ICL for him. It was straightforward, with all measurements had been taken before surgery. Post-operatively, in this eye, the vision didn't improve. It reached only 0.3 with a lot of pigments on the back of the cornea and on the ICL, and the pressure was high, up to 30 millimeter mercury. Cornea shows heavily pigmented trabecular meshwork. What we missed here, that we didn't do gonioscopy for this patient, and none of us is doing gonioscopy for patients for ICL. Is high myope, expecting that the angle is wide. And the point is that, and I do thank Dr. Nada Medhat for helping me in solving the problem of this patient, because I didn't understand why the patient has this high pressure with everything is okay for the ICL. And she told me that this posterior bowing of the iris is an indicator of the pigment dispersion syndrome. And we missed this posterior bowing. This is a preoperative picture of the patient as I'm doing routinely for all these patients, the MS39 showing the anterior segment OCT. And definitely when we examined the angle at that time, we found the heavily pigmented angle, and this was a pigment dispersion syndrome. So the decision was, this is after the surgery, how this ICL made the angle closed with the high intraocular pressure. So the decision to remove the ICL, doing phaco and trifocal IOL, because he is young, aiming for good vision. And after this procedure, still the intraocular pressure did not, we didn't control it, and he had improved vision. And then we, after doing this surgery, which is the removal of the ICL, and as you all know, the removal of ICL is easy, no problem. You can remove it from the same incision because it is highly foldable copolymer material, so you don't need to cut the ICL from inside, and advisable not to enlarge the wound to do your phaco surgery. And as you see here, the iris is floppy, and this is another point that see this iris is redundant. And when you do the surgery, you'll find the fluctuation and the movement of the iris, which is another sign for the pigment dispersion syndrome with this iris, which is usually fluctuating in this manner. As you see here, the iris is coming in and out and constricting and dilating with the regular pressure. And we inserted the trifocal for him, and he regained good vision, definitely not like the right eye, but at least we gave him valuable vision. Of course, all these are on your expenses, not the patient's expenses. So we did for him after that trabeculectomy, and this is another patient that had the same problem also, and on the routine examination for him and doing clear lens extraction, I'm doing routine OCT. I found another patient ICL with an active CNV, myopic CNV. This patient is all of the time annoyed because even after removal of the ICL and putting, this is another patient, and putting the IOL, the patient did not improve in vision because he has an active myopic CNV. So this is the patient after 1 day and the intravitreal injection of anti-VEGF. The vision improved to 0.5, and he is still injecting up till now, but of course is not happy. So the take-home message is long life follow-up for patients with LASIK. Flat complications should be considered even after 10 and 15 years. Even PRK has a risk of bilateral fungal and bacterial infection. Thorough measurements and calculations for ICL before surgery is mandatory. Pigment dispersion syndrome is a missing point and is not uncommon. Gonio examination should be considered, and anterior segment OCT are mandatory before ICL, or the best thing is not to do refractive surgery. No more refractive surgery. Thank you so much.